So let's start. Today's lecture will be devoted to the anemias. One of the most common syndrome for the polyclinical therapy that's commonly met in all conditions. In the case of the outpatient, diagnosis in the case of the inpatient problems and so on. So how do we understand what it means, anemia? It is, a not so specific syndrome that's commonly defined as a decrease in the number of the erythrocytes or the level of the hemoglobin due to different mechanisms like blood loss, impaired production of the red blood cells, their increased destruction, or combination of these factors. So as we can see, different mechanisms can be associated with the anemia, but the subsequent findings, pathological findings in the peripheral blood, pathological findings in the, in diagnostic methods can be quite common. What else I have to say about anemia? In general, if we speak, for example, about the most common, most frequent type of the anemia, iron deficiency anemia, usually, iron deficiency anemia itself is not so dangerous, but we should not forget that the population that is usually attached to the, attending physician, especially to the therapeutist, it is adult population with some chronic, not infectious diseases like the cardiovascular problems, GIT problems, and so on. And anemia can complicate any concomitant process. If the patient, for example, has atherosclerosis, the certain vessels affected by the atherosclerotic plaque. If we talk about the cerebral vessels and the same patient also has anemia, two factors combined, decreased blood supply to the cerebral tissue, decreased oxygen supply due to anemia, that can lead to ischemic stroke. So that is why there can be different combinations of the chronic non-infectious diseases and associated anemia. Anemia must be always detected with attention because anemia can be associated with the different reasons and timely treated just to prevent the influence of the anemic process on any other concomitant disease. So, firstly, some words about the pathogenesis, the normal production of the red blood cells. As we can remember, erythrocytes are being produced in the bone marrow. And there are several stages of their development, starting from the erythron. This is definition for the system, normally functioning system of the bone marrow, of some physiological factors leading to the normal erythropoiesis. And so the normally functioning erythron consists of several elements. Firstly, stem cell, the precursor of the myelopoiesis, precursor of the erythropoiesis, intermediate stages of the red blood cells, not major stages like pro-erythroblast, erythroblast, normoblast, as we can see, they're associated with the nucleus within. After that, also major forms, reticulocytes, and finally, major red blood cell, erythrocyte without any nucleus, the major cell that's absolutely able to complete its main functions, like the oxygen supply and iron element supply. So, in the case of the normoblast, it can be characterized with the two types, megaloblast and sideroblast. They usually appear in the peripheral blood with the myelofibrosis, complications of the cancer. So in the case of the malignancy complicated by metastasis, myelodysplastic syndrome, hemolysis. So, of course, the appearance of the normoblasts in the peripheral blood is absolutely abnormal, and it can be associated with many pathological conditions. When we speak, for example, about acute or chronic leukemia, also associated types of the white blood cells, not mature white blood cells, can also appear in the peripheral blood. And so the similar condition when we speak about the myelodysplastic syndrome and additional, I would say, amplified accumulation and amplified production of the red blood cells. Diagnostic criteria for anemia, they're quite easy. We should take a look at the hemoglobin and, the red blood cell count, RBC. For adult male population, hemoglobin is lower than 130. Some laboratories work with the gram per deciliter. So this general hemoglobin should be subdivided by 10. So 13 gram per deciliter. Usually, for example, the European criteria, they commonly use gram per deciliter. Here in Russia, we got accustomed to a gram per liter. Red blood cells, erythrocytes, lower than 4. For female population, requirements are different. Please pay attention. Hemoglobin level less than 120, erythrocytes less than 3.5. Of course, it is just, I would say, the cutoff values of the anemia. How can we detect this pathological syndrome for sure? In the practice, we must diagnose the hemoglobin level, the level of the red blood cells in the dynamic, just to see, well, if hemoglobin is being decreased during certain time, so soon anemia will come. Or maybe even when the hemoglobin or erythrocytes are normal, it doesn't exclude the presence of the anemia. For example, some stages of the iron deficiency, surprisingly, at the first sight, can be associated with the normal hemoglobin and the normal erythrocytes. But the pathological mechanisms leading to anemia exist, and pathological process is, is developed right now in the moment. And so we should not, our attention should be focused not only on the hemoglobin and red blood cells, because some biochemical analysis, some biochemical findings that we are going to consider today are also attached to the anemia signs and, laboratory diagnosis. Sorry. The relative distribution of the fluid in the body, of course, will have the certain affection on the red blood cell assessment, also on the content of the hemoglobin and hematocrit in the blood. So the general values, because usually, for example, the hematocrit, the percents, they are calculated not with the absolute numbers. So in the case of the, for example, increased accumulation of the fluid within the bloodstream, the relative number of the red blood cells can be decreased, so that will lead to the hematocrit decreasing. And of course, anemia signs will be detected, but maybe it's not anemia at all. So, relative increase in the plasma volume, disproportionately, surprisingly low hematocrit can be associated with the increased fluid, for example, during the pregnancy, especially, of course, during the last trimester, an increase in fluid in the body, while oliguria presents with the renal failure or with the severe heart failure. In the case of the chronic diseases, like, for example, cirrhosis, liver insufficiency, decreased synthesis of the albumins will also lead to increased fluid accumulation. Prolonged line position, splenomegaly, these conditions can be associated with the low hematocrit. So some other conditions must be also, assessed and firstly excluded before we will start treatment of the anemia. Normally, every time when we speak about the true anemia associated with the red blood cells and hemoglobin decreasing, the first physiological reaction, it is activation of the erythropoiesis. So the sense is quite easy. When the body, when the organism, lost some red blood cell due to any reasons, the first task of the bone marrow is to activate erythropoiesis, just to compensate the current, for example, blood loss or the current, malfunction of the red blood cells. So in all the cases when the homeostatic system functions normally, when there are no any pathological mechanisms that would affect erythron, that would affect conditions of the bone marrow, when the maturation process of the red blood cells is not violated, in this case, the degree of activation of the erythroid lineage is directly proportional to the severity of anemia. In other words, the more severe is anemia, the more activated bone marrow is. But only in the normal conditions. So, for example, in the clinic, we can meet such, situation when, for example, the hemolytic anemia presence, or any other types, for example, after surgery, after large surgical intervention, when the patient, lost some volume of blood, we just, we expect increasing of the hematopoiesis because it's supposed to be normally. Bone marrow must compensate the previous blood loss. But when we do not see this activated erythron, this increased level of the reticulocytes, when we do not see increased level of the red blood cells, it means something is wrong with the bone marrow. And in this case, additional diagnostic steps must be undertaken. So, the increased production of the erythroid cells normally reflects an increase in circulating reticulocytes in the blood. As we discussed before, reticulocytes are, the preform of the red blood cells right before the mature one, reticulocyte. So there is specific index that we calculate considering hematological data, namely RPI, reticulocyte proliferative index. The kinetic classification of anemias is based on this index. Well, today we commonly consider two classifications of the anemias. Morphological, based on the morphological elements, morphological characteristics of the red blood cells. And another one, kinetic classification, based on the RPI. Kinetic classification is more frequently used in the practice because it's just much more convenient. So here it is, RPI, reticulocyte proliferative index. Please pay attention to the formula. RPI should be calculated considering percents in the reticulocytes into hematocrit in percents and divided by maturation time of the reticulocytes in days into 45. Well, this formula includes hematocrit just as a relative measure of the blood volume. Because in all the cases when the blood volume is increased and hematocrit is low, we must consider the situation when fluid accumulation will affect the reticulocyte count. And that's why we need to consider ratio between the hematocrit divided by 45. This is ratio as a ratio between the current hematocrit and expected or normal hematocrit for adult person. Another element of this formula, maturation time of the reticulocytes in days, also, commonly correlates with the hematocrit. Normally, 1 day is needed for the reticulocyte to get mature. So, to turn into mature red blood cell, into mature erythrocyte. But considering anemic process, this time can be prolonged, pathologically prolonged. So, for example, when the hematocrit is very low, for example, 25%, it will take 2 days for the immature reticulocyte to get mature. And this maturation time must be always considered, because we should not make any conclusion based on the immature reticulocytes. We must consider only mature forms. So, for example, the patient has hematocrit 25%, the number of the reticulocytes 20%, and maturation time with this level of the hematocrit is equal to 2 days. RPI, considering this formula, will be equal to 5.5. Associated with the RPI more than 3, please pay attention. Increased production of the red blood cells is when RPI more than 3. When RPI is less than 2, this is impaired erythrocyte production. The normal, healthy value of the RPI should be between 0.5 up to 2.5%. But you can say, right now, I told you RPI less than 2, it is impaired production. But, for example, 1% for the healthy individual, it is normal. Yes, of course, but students, we are speaking about the anemia. And that above mentioned criteria, so RPI less than 2 or RPI more than 3, it is when patient has anemia signs. Any other findings, for example, red blood cells decreased, hematocrit decreased, hemoglobin decreased, and so on. But the healthy individual who doesn't have any signs of the anemia, for him, normal value of the RPI will be different. That's it. So we must understand that in the pathological condition, the formula and the conclusion based on the RPI will be made in the different way. So we should not use the normal requirements for the patient with the anemia. Based on the kinetic classification of the anemias, we commonly subdivide them into 2 types. The first big type, anemia associated with the impaired production of the red blood cells, RPI less than 2, including hyperproliferative anemias. Hyperproliferative, it means anemias associated with the, decreased proliferation of the red blood cell lineage in the bone marrow. For example, iron deficiency can lead to that. Not enough supply of the iron, or maybe some problems with the iron absorption in the JT. There will be hyperproliferation because iron content is absolutely essential for the normal erythropoiesis. Anemia of the chronic diseases, the chronic inflammation mostly is included. In this case, like for example, COPD, any other chronic conditions, repeated pneumonia is commonly associated with this. The chronic inflammation will also lead to hyperproliferation. The mechanisms are different. Even in the case of the normal iron supply, there will be some problem with the, iron enter to the cell due to inflammation problems. Another situation of the hyperproliferative anemias, it is decreased production of the APO, if you remember that, erythropoietin. that is produced in the peritubular lining of the kidneys, and this substance is one of the most potent activators for the bone marrow. And erythropoietin production is, I would say, closely involved into the process of normal erythropoiesis. Any types of the, for example, let's say, anemic condition, decreased oxygen, erythropoietin will be activated at once and leading to the increased production of the red blood cells in the bone marrow. So anemic and the hypoxic mechanism will be compensated. Hypoplastic anemia, hypoplastic, it means when the bone marrow is primarily affected and the certain, I would say, morphological elements of the bone marrow are replaced by the, for example, well, lipid components. So when the normal tissue of the bone marrow is replaced by pathological tissue. Of course, pathological tissue cannot any longer complete the purpose of the normal erythropoiesis. Aplastic anemia, as a consequence of the bone marrow replacement, as a consequence of, for example, too frequent radiological treatment, influence of the X-ray, and so on. Also, bone marrow infiltration in the case of some malignancy of blood, leukemia, mostly acute leukemia, of course, will be associated with the anemia, but the chronic leukemia can also lead to that. Tumor, myelofibrosis, and so on. The second part of the anemias with the impaired production, when the RPI is less than 2, they are due to ineffective erythropoiesis. Well, first type, megaloblastic type, commonly known B12 deficiency. Folic acid deficiency, quite similar to the B12, or maybe mixed type. Well, microcytic types of the anemias. Thalassemia, sideroblastic anemias, normocytic anemias with the certain, for example, DNA violation and so on. Sorry. The second big group of the kinetic calcification, it is anemia with increased production of the red blood cell, RPI more than 3. In this case, we mostly talk about hemolysis. Well, intravascular hemolysis that can be congenital or acquired. Also, anemia with the total parenteral nutrition, but also it will lead to the hemolysis. And post-hemorrhagic anemia, early period after massive bleeding. Please, students, I must also focus your attention here. Post-hemorrhagic situation. I have already told you about that. So, normally, when the bone marrow is not affected at all, after certain hemorrhagic process, especially after massive bleeding, bone marrow will be significantly activated. And in this case, well, red blood cell, I would say erythropoiesis will be activated, reticulocytes will be increased, RPI will also get increased. In this case, if we do not see, because it's not uncommon when even after hemorrhagic process, reticulocytes are not increased. We must think about the bone marrow pathology in this case. Otherwise, some serious complications can be, I would say, can be left undetected. Another type of the classification, this is morphology, based on the assessment of the size of the red blood cell, including volume, diameter, area, cell thickness, intracellular hemoglobin concentration, construction of the distribution curve of the erythrocyte. All anemias are subdivided into 3 types: macrocytic, with the large volume of the red blood cells, increased size of the erythrocytes, more than 100 femtoliters. Normocytic, when mean cellular volume MCV is in between 80 up to 100 femtoliters, and microcytic, with the small types of the erythrocytes, when the MCV is less than 80. So in these cases, we can see morphological classification. We commonly consider size of the erythrocytes. Macrocytic anemia, the first type, when the MCV is more than 100 femtoliters, they are subdivided into megaloblastic and non-megaloblastic. Megaloblastic associated with the certain, I would say, features of the erythropoiesis, megaloblastic type of the anemia in the bone marrow with the B12 deficiency, for example. Well, actually, both classifications, kinetic and morphological classification, they take a look at the same problem, but from the different sides. And so, on my opinion, kinetic classification is much more, I would say, convenient for the clinical assessment because it will take less time. But morphological classification will give us chance to understand mechanisms better. Well, megaloblastic anemias are, so how to say, dependent on the predominant cause, can be associated with the B12 deficiency, first of all, the most frequent course. And in this case, the most commonly, I would say, most frequent leading causes are lack or absence of intrinsic causal factor in the stomach, so-called pernicious anemia, after the stomach surgery, or in the case of the influence of some poisoning. Also, dysfunction of the intrinsic factor, biological competition in the case of the certain, well, bacterial overload, and in other forms of the infections. Also, B12, well, megaloblastic anemia can be caused by the lower absorption of B12 vitamin, drug-related vitamin B12, the chronic disease of the pancreas, including Zollinger-Ellison syndrome, gastrinoma, if you remember, after the courses of hemodialysis, disease of the ileum, and so on. But as I said before, the most common reason for the megaloblastic anemia, it is deficiency of B12 vitamin. Sorry. Folate deficiency can also lead to the similar problems. And usually, in the case of the clinical symptoms, in the case of the laboratory findings, folate deficiency is very similar to the B12 deficiency. Or maybe they can be, of course, combined deficiency of B12, of vitamin B12 and folic acid. DNA synthesis violation can also lead to the megaloblastic type of the anemia. Of course, the congenital disease of this type are very, very rare. Drug and toxin-induced violation of DNA synthesis with the certain types of the mentioned, well, harmful substances and the poison substances. Erythroleukemia can also lead to a megaloblastic type of anemia, associated condition of the bone marrow. Non-megaloblastic type, another part of the macrocytic anemia, not associated with the megaloblastic type of erythropoiesis. Well, hemolytic anemia, post-hemorrhagic type, liver disease, obstructive jaundice, myelodysplastic syndrome, alcoholism, sideroblastic anemia, and so on. Microcytic and hypochromic anemias. Microcytic, MCV is less than 80 femtoliters. small red blood cells are detected. Iron deficiency anemia, anemia of chronic disease, absence of the transferrin, congenital hypochromic microcytic anemia, antibodies to the transferrin receptor, intoxications with the certain substances, secondary copper deficiency, well, violation of the globin synthesis, sideroblastic anemias. But one of the most frequent type of the macrocytic anemia, of course, it is iron deficiency, especially later stages of the iron deficiency, because firstly, in the, let's say, early stages, the size of the red blood cells will be normal even for the iron deficiency. And so in this case, we will see that in this classification. Normocytic and normochromic anemia. Anemia associated with the increased production of the red blood cells. As we mentioned before, post-hemorrhagic process can be associated with the megaloblastic type of erythropoiesis or with the normocytic. That depends on the bone marrow. Hemolytic type of anemia is commonly associated with the normocytic anemia. What else? Inadequate bone marrow response, diseases of the hematopoietic system. Most commonly, they are diseases of the bone marrow. Aplastic anemia, leukemia, myeloma, myelodysplastic syndrome, and so on. Decreased production of the APO, the certain damage of the kidney tissue, for example, chronic kidney disease, decreased stimulation of endocrine insufficiency, anemia of the chronic disease, the chronic inflammation especially. Iron deficiency in the early stages, please pay attention. Iron deficiency can be associated either with the normocytic or microcytic, with the small red blood cells, depending on the stage of development. If we speak about the early iron deficiency, so latent stage, for example, mean cellular volume, the size of the red blood cell will be normal. And of course, we will not detect the anemia if we consider only on the MCV. But for the later stages, well, early or late iron deficiency, in this case, the mean cellular volume of the red blood cells will get decreased and microcytic type of anemia will be detected. In addition to the previous two classifications, so kinetic and morphological one, every type of the anemia can also be classified depending on the severity, directly by the level of the hemoglobin. Mild anemia, when the hemoglobin more than 90 gram per deciliter, moderate from 70 to 90, and severe when hemoglobin is less than 70. Here are some normal red blood cell count. Well, you can download this lecture, students, and actually I recommend you to print these counts before your practical classes will be started. I do not ask you to learn all of these elements by heart, but I want you to understand the, staging character of anemia, especially of the iron deficiency, from the very beginning, from some risk factors influence, and right till the end, when the clinical symptoms will be detected. We need to realize the stepping character of anemia, considering hemoglobin, considering level of the red blood cell, considering hematocrit, considering the level of the iron stores, namely serum ferritin level for male and for female population. We must consider serum iron. We must consider level of the erythropoietin. We must consider level of the, they will be mentioned later, of the TIBC, total iron bending capacity. We must consider such value like the transferrin saturation with the iron, I mean. Well, we must consider the vitamin B12, folic acid, in order to, well, to differentiate between the B12 deficiency or folic acid deficiency. Diagnostic algorithm. Anemia as a pathological syndrome is usually detected occasionally. The patient usually does not have any complaints. So anemia most commonly it is subclinical syndrome. So the clinical blood test, morphological analysis of the peripheral blood, calculation of the erythrocyte indices. So of course, as usually we will start with the CBC. When we see the level of the hemoglobin decreased, when we see level of the red blood cells decreased, of course, we will think about anemia. But one more time, students, I focus your attention. Anemia can be present even when the hemoglobin and the red blood cells count are normal. And so, please consider the second stage, the second step of this algorithm, biochemical research. Biochemical blood analysis must be undertaken in addition to the CBC, because biochemical analysis is much more sensitive in comparison with the CBC. Early stages of the iron deficiency will be not detected by CBC, but biochemical values will give us information, necessary information to understand at which stage of the iron deficiency our patient is. Biochemical research includes, for example, serum iron, serum ferritin, transferrin saturation, total iron bending capacity. Usually these values of the biochemical analysis are enough to make a conclusion about anemia stage. The next, we can also go for morphological analysis of the bone marrow smear, so-called melogram. After that, bone marrow histological examination, but there are, well, we must have some indications, specific indications for bone marrow histology. For example, when we suspect any bone marrow insufficiency, aplastic anemia, B12 anemia must also be confirmed by the bone marrow histology. We must directly see megaloblastic type of the erythropoiesis. There are also some special laboratory methods like hemoglobin electrophoresis, determination of the erythrocyte enzymes, but usually they're used for rare diseases and usually not included into the basic volume of the medical search. And final instrumental research methods. Anemia, especially later stages of anemia, can be associated with some, well, I would say, another systems of organs violations. They can be additional GIT problems, the certain malfunction of the esophagus, and in this case, for example, X-ray method, well, echo of the heart in order to see the velocity of the bloodstream. It can also be helpful. Here are the examples of the peripheral blood smear. On the right, we can see normal red blood cells. On the left, we can see microcytosis and hypochromia. As we can see, so the size of the red blood cells is decreased, the form is being changed, and the general size is small. So we speak about the later stages of the iron deficiency usually. Another, well, findings, another volumes that are that are used for the anemia diagnosis are CPU or color index, not source specific, and usually nowadays not so frequently used in the practice, because instead of the color index, we have much more sensitive values like MCH, mean cellular hemoglobin, and MCHC, mean cell hemoglobin concentration. But nevertheless, some laboratories can also be, I would say, uh, working with the color index. The formula is mentioned on this slide. We need to take hemoglobin level into 3 and divide it by the first 3 digits of the number of erythrocytes without any comma. For example, if the patient has level of the red blood cells 4.78 and the quantity of hemoglobin 120, we will take 120 into 3 divided by 478 without comma. So equal to 0.75. Well, commonly CPU color index should be around 1. So this is ratio. So it doesn't have any units of measurement. This ratio gives the idea about the, I would say, average distribution of the hemoglobin per total quantity of red blood cells. And as I said before, there are more specific, more sensitive values like MCH, mean cell hemoglobin, that's calculated considering the hemoglobin divided by red blood cell. And MCHC, hemoglobin divided by hematocrit, or MCH divided by MCV, mean cellular value. Considering these values, so MCV, size of the red blood cells, we will differentiate between normocytic, 80 to 100, macrocytic, more than 100 femtoliters, and less than 80 femtoliters, microcytic. And 2 latest values, MCH and MCHC, we will differentiate between the normochromic, hyperchromic, and hypochromic. As an example of the hypochromic anemia, for example, it is late stages of the iron deficiency. Hyperchromic, it is B12 vitamin deficiency. Algorithm. The necessary steps to differentiate between the all anemias depending on the pathological mechanism. When we can see that the patient is present with the hypochromic, so color index decreased, MCH decreased, MCHC decreased, and or microcytic anemia, MCV is decreased. The next, we must take a look at the serum iron. When it's decreased, most common situation, the next, we must take a look at the serum ferritin. This protein, I would say, it shows the iron store in the body. The more is the iron storage, the more is the level of the ferritin. When the ferritin is decreased, what means there are some mechanisms that lead to the iron stores depletion. It is iron deficiency anemia. When the ferritin is normal or increased, that excludes diagnosis of the iron deficiency anemia. Ferritin cannot be normal for that. It could be anemia of the chronic diseases. That's it. If the serum iron, coming back to the first title, serum iron level is normal, that could be thalassemia or the certain types of the hemoglobinopathies, rare situation. Or serum iron is increased. That could be sideroacristic anemia, increased level of the sideroblasts in the bone marrow. Macrocytic type. Macrocytic, as we discussed before, macrocytic anemias are subdivided into megaloblastic and non-megaloblastic type. Well, the first step, when we see that the patient is present with the macrocytic anemia, what is that? MCV is increased more than 100 femtoliters. We must take a look at the morphology of the blood and the bone marrow. Because without bone marrow picture, we cannot see type of the erythropoiesis. If after bone marrow histology we can see that there is megaloblastic type of erythropoiesis, the next step we must determine the level of B12 and folic acid. And in the case of the maybe single deficiency B12 or folic acid, or maybe combined deficiency of both elements, we will make the corresponding conclusion. B12 deficiency, it is B12 deficiency anemia. Folic acid is not enough. Folate deficiency, B12 and folic acid combined, that could be malabsorption from the small intestine. If the level of the B12 vitamin and folic acid are normal, but the megaloblastic type is detected, we must exclude hereditary diseases or maybe drug-induced type of the megaloblastic. Coming back, well, microcytic anemia, non-megaloblastic type of the erythropoiesis. When we took the bone marrow histology and no any megaloblastic type of erythropoiesis has been revealed. The next step, we must take a look at the reticulocyte count. Increased level of the RPI, more than 3, bleeding, hemolysis. Hemolysis also the consequence after the massive blood loss. What else? After, as we mentioned before, the long course of the intravascular nutrition. In the case of the normal level of the RPI, that could be liver disease, cirrhosis, hypothyroidism, myelodysplastic syndrome, aplastic anemia. Normocytic type and normochromic type of anemias. We took a look at the reticulocytes. If they're increased, we must consider anamnesis, bilirubin level, in order to exclude post-hemorrhagic type or hemolytic anemia. In the case when the reticulocytes are normal or decreased, so we will take a look at the ferritin level. When the ferritin level is normal, that could be latent B12 deficiency, myelodysplastic syndrome, aplastic anemia, liver disease, kidney disease, and so on. When the ferritin level is increased, it is chronic disease anemia. That's it. If the level of the ferritin is decreased and the anemia is characterized with the normocytic type, that could be the early stages of the iron deficiency also. Now, well, we will consider with the details iron deficiency anemia. It is clinical and hematological syndrome. So that is characterized by the violation of the hemoglobin synthesis as a result of iron deficiency that can be developed due to pathological or physiological processes. So iron deficiency anemia sometimes can be, I would say, associated with the physiological conditions. When we consider, for example, not only decreased iron supply, but also increased demand and the increased, I would say, metabolism of the iron contents. And of course, both processes will lead to the signs of the anemia and sideropenia. Anemia, students, it is signs of the decreased oxygen. Sideropenia, signs and the pathological mechanisms caused by the iron content decreasing. Iron deficiency anemia is very, very frequent condition. As I said before, the latent iron deficiency, well, is very common. More than 3.5 billion of the Earth inhabitants are affected by the latent iron deficiency. No signs, well, no complaints, only some abnormalities of the biochemical analysis of the blood. And of course, in the most conditions of that, iron deficiency remains undetected. Well, the main reasons for the iron deficiency, that could be bleeding, well, acute bleeding, the chronic bleeding, gastrointestinal bleeding most commonly, uterine bleeding or the menses periods, nosebleeds, usually, for example, for child population, elementary insufficiency, the lack of the iron supplement with the food, impaired assimilation, for example, when there is, how would say, decreased acid production in the stomach, and iron content, iron cannot be assimilated without this reaction. Increased consumption of the iron, for example, the periods of active growth within childhood. What else? Increased consumption, malignancy. Malignant cells will always require more iron than normally. Pregnancy, another physiological condition associated with the increased demand and consumption of the iron. What else there? For example, involvement into sport, the, how to say, heavy physical exercises will also require more iron for the muscle tissue. That's it. So not all of the situations associated with iron deficiency are pathological. We should not forget about that. Distribution of iron in the body. Most are, well, distributed in the hemoglobin. There are some stores of the ferritin in the liver, spleen, in the muscle, so myoglobin content, iron-containing enzymes, and, well, the least part it is within transferrin or serum iron. Stages of the iron deficiency in the body. 4 stages are commonly made: prelatent, latent, and 2 stages of the iron deficiency, of the true iron deficiency: early IDA and late IDA. Here are they, students. On this table, we can see the most specific types of the specific findings for the iron deficiency anemia. 4 stages: prelatent, latent, early, and late iron deficiency. Well, of course, different mechanisms are associated with each stage. Well, considering the predominant causes, decreased iron supply, or maybe combined, when the decreased supply is combined with the iron demand increasing. The first stage, related. The main, I would say, essence is, at this stage, only risk factors presence. What does it mean? The patient doesn't have any signs of the anemia, nor any complaints, because, well, the problem here is the storage of the iron content starts to get depleted. It is very first stage associated with the iron content in the bone marrow decreased and serum ferritin. So the most important protein associated with the iron storage in the body decreased. So in this stage, for example, the patient can have condition after the bleeding, so the certain blood loss can be typical. And in order to compensate the certain blood loss, bone marrow will take will take iron from the previously storaged ferritin. And the storage of the serum ferritin, of course, will have to be decreased, but not yet absent, not yet depleted. So this is the process for latent stage when the storage of the iron can be successfully used to compensate starting anemia. And so, of course, prelatent stage is not associated with any problem. Transferrin saturation will be normal. Hemoglobin is not decreased because bone marrow is functioning normally, considering previously storaged iron. MCV is normal, serum iron is normal, TIBC is normal. There is only increased iron absorption if we can detect that. So prelatent stage is very beginning. In time, latent stage will come. Latent stage will be associated with the absent content of iron in the bone marrow. So by this stage, the stores of the iron in the bone marrow are absent, depleted. There is nothing else that we can use for the normal erythropoiesis. And in this case, some other biochemical signs will be detected. By this stage, by the stage of the latent iron deficiency, well, a transferrin saturation will be a little lower than normal. Serum iron will be less than normal, and total iron binding capacity will start to increase more than 69%. That's it. After that, with time, process gets severe, it becomes more severe, early iron deficiency will happen. And so, what are those differences between latent stage and early iron deficiency? Please take a look. Hemoglobin. Hemoglobin value for the latent stage is normal. For the early iron deficiency, gram per deciliter, 8 to 12. It is decreased. MCV for the latent stage, normal. What means the size of the red blood cells is not validated. And for early iron deficiency, it can be decreased. The early iron deficiency, it is the early stage when the very first microcytic red blood cells can be detected in the peripheral blood. And in this case, it will require sensitive tool to assess, or maybe experienced medical staff in order to get this very first macrocytic type of the red blood cell. Serum iron will not increase right till the end unless iron supplements will be given. Total iron binding capacity will be increased higher. So as we can see, total iron binding capacity, it is indirect measure of the transferrin saturation. When the transferrin saturation is decreased, total iron binding capacity will be decreased. It is just like the rule. On the practical classes, I will give you detailed explanation what it means and why it happens. And finally, late stage of the iron deficiency. Serum ferritin less than 10, hemoglobin less than 8, MCV is always decreased. So by this stage, there can be no any normal size of the red blood cell. Every erythrocyte is small. Total iron binding capacity more than 85%. And please pay attention, epithelial changes. Cytopenic symptoms will be detected by the time of the late iron deficiency. The diagnosis. Of course, when we detect some symptoms, our task will be much more easier. But usually, anemia is subclinical condition. Some patients can have symptoms only of the underlying or concomitant diseases. And so, for example, patient has stable angina, ischemic heart disease, and in the case of the anemia decompensation, maybe it will lead not to the anemia signs, but it will lead to the functional class of the angina decompensated. That's it. We must consider the presence of the concomitant pathology too. The clinical manifestation of the iron deficiency includes anemic syndrome and sideropenic syndrome. Anemic syndrome, well, pathological findings caused by the oxygen lack, how to say, a decreased supply of the oxygen by the red blood cell. Example can be like weakness, decreased physical tolerance, pallor of skin, dizziness, noise in the ears, flashing flies before patient's eyes, heartbeat, shortness of breath and exertion, fainting, hypertension. If the patient has any concomitant disease of the cardiovascular system, their concomitant disturbance, like the decompensation of the heart failure, worsening of the coronary artery disease, the dyscirculatory encephalopathies, and so on. So sometimes, as I said before, anemia is manifested with the signs of the concomitant diseases. Here are they. Sideropenia. So, how to say, symptoms caused by the iron content depletion, iron supply decreasing. That's associated with certain problems of the skin, JT, nervous system, cardiovascular system, muscle tissue. The symptoms of the anemia and sideropenia cannot be differentiated for sure because they're quite similar. And when we speak about the iron deficiency anemia, both parts of the clinical manifestation will happen, both including anemic and sideropenic syndrome. So we cannot say for sure if this general weakness caused by the sideropenia or anemia. We need to consider both symptoms combined. Also, decreased performance and exercise tolerance, inability to concentrate, memory loss, prolonged asthenic syndrome after previous infections can be the signs of the sideropenia. There can also be the certain problems of the skin, like the brittle nails, stratification of nails, flattening, dullness, spoon-like shape, inability to grow long nails or hairs, for example, splitting hair ends, quite common complaint of the female population. Here are they. Well, pallor dullness of the nail bed in the patient with the dark skin. Well, in this case, when we cannot see the pallor skin on the hands, we must take a look at some areas only. So this is nail bed and the area of tenor and hypotenor. In these areas, the signs of the anemia can be detected easier. Iron deficiency anemia, thin, brittle nails. Sideropenia signs continue. They can be perversion of taste, patophagia, for example, when the patient with the usually long time existing anemia surprisingly wants to eat chalk, ash, earth, and sometimes so unusual addiction to, I would say, odors. So how would say, not pleasant smells like acetone, gasoline. With the anemia, this condition can also be present. And of course, this can become additional, how would say, confirming factor for the clinical diagnosis. Well, evaluation of the integrity of the epidermis, considering angular stomatitis, glossitis, flattened papillar, burning sensation of the tongue can also be associated with the iron deficiency. Here it is. Well, angular stomatitis, condition of the tongue, atrophy, the flattening of the papilla in the tongue with the long course of the iron deficiency. Also, dysphagia can be caused by the sideropenia, swallowing disorder, well, dysuria, and urinary incontinence on the coughing, laughing. During the night, nocturnal aneurysms can be also happen. Well, I told you about the additional instrumental methods for the anemia conclusion. Here it is, X-ray. Well, in order to detect the swallowing disorder and the spasm of the esophagus, when we can see when the contrast cannot, enter towards the remaining parts of the esophagus. Blue sclerosis symptom when we take a look at the patient's eyes. Another example, the clinical example of the iron deficiency anemia. Pallor of the skin and mucous membranes. The skin looks like white. Neuralgia as a rare symptom, decreased sensitivity, feeling of the goosebumps, possibly increased intracranial pressure within the adolescents or children, increased susceptibility to infections, possible increased menorrhagia, the appearance of the hemorrhages in the ocular fundus. That's it. Multiple retinal hemorrhages with the patient with severe iron deficiency and profuse menorrhagia. In the case of the elderly population and elderly patient, iron deficiency anemia can be manifested differently. They will get adapted to the low hemoglobin. Low severity of the hypersiderosis in relation to the skin and mucous membranes. Polymorbidity. This population will have different concomitant pathology, different diseases, and anemia is usually associated with the decompensation and unstable course of the previously developed diseases here. Frequent combination of the several etiological factors, like for example, the chronic inflammation anemia, decreased absorption of the iron, and so on. Combination of several anemias, IDA, B12 deficiency, folate deficiency, the difficulty and the complexity of diagnosis and treatment. Bleeding duodenal ulcer, one of the most common reasons for the iron deficiency. Even subclinical ulcer, the chronic bleeding associated with the positive result of the fecal occult blood test is one of the most common conditions. And of course, when we suspect the iron deficiency anemia, endoscopical assessment of the JT, especially of the condition of the stomach and duodenum, is absolutely necessary. Malignancy can also be another reason for the iron deficiency. Adenocarcinoma of the large intestine, increased accumulation and increased metabolism of the iron for the malignant cells is the cause here. Laboratory signs of the iron deficiency. We have already actually considered all of them, divided by the stages, 4 stages of the IDA. Low color index, decreased hemoglobin concentration, decreased size, microcytosis, decreased MCV, anisocytosis, changed size, poikilocytosis, changed form of the red blood cells, decreased serum iron, increased IBC, decreased transferrin saturation, decreased ferritin, and so on. These are most common and most necessary findings. These types we have already seen before: microcytosis, hypochromia, poikilocytosis in comparison with the normal condition. Bone marrow morphology: microneuroblastic erythropoiesis. Erythroblast cytoplasm is scanty, vacuolated, and irregular, the absence of sideroblasts. But usually, the iron deficiency does not require the bone marrow histology, just not needed. Biochemical analysis is the most necessary. So the treatment principles for the iron deficiency, please take your attention. First of all, we must eliminate the cause of the anemia. For example, the bleeding ulcer, the chronic inflammation, well, any other condition that can be associated with the blood loss of the certain type. After that, we must give iron replacement therapy. Well, since iron deficiency anemia is commonly caused by the iron, I would say, iron supply decreasing, we must give something in the replacement. And in this case, iron replacement therapy is quite long treatment, up to 6 months sometimes. Please pay attention, because there are different, I would say, stages and the purposes of the iron deficiency anemia treatment. When we consider the required daily dose of elemental iron, depending on the age, for adult population, it's usually 200 up to 300 milligrams per day. And for the patient with the anemia, we must give this quantity of the iron, elemental iron, every day. How can we do that? Well, the treatment of the iron deficiency is subdivided into oral therapy. So when the iron complements are given peros, or parenteral therapy. Indications for parenteral therapy will be considered later. So now usually we'll start with the oral therapy with the iron deficiency anemia. For example, sorbifer duralase, the drug that consists of iron sulfate and ascorbic acid. In order to, I would say, make it easy, the process of the iron absorption. Please, students, I want you to pay your attention. Well, every tablet of the sorbifer duralase, well, has the total weight 320 milligrams, and well, after the slash we can see 100 milligrams. It is the content of elemental iron within one tablet of the sorbifer duralase. And actually, in the recipes, of the iron supplements, they will be always given in the same way. Firstly, the total weight is mentioned, and after that, the content of elemental iron, dependent on the previous information. So every day we must give 2 up to 300 of elemental iron. And so, for example, sorbifer duralase should be given 3 times a day. That's it. Ginoterdifferon, for example, elemental iron content equal to 80 milligrams. So when we reach, for example, 300 mg per day, we will have to use around 4 intake of the ginoterdifferon per day. That's it. There are very numerous iron complements and iron preparations. The main essence must be considered is the content of elemental iron per each tablet. So we must consider the everyday dose. Ferrous fumarate, iron polyisomaltosate, hydroxide sucrose complex, and so on. So, in which cases we must go for the parenteral therapy? When we detect malabsorption of the intestinal pathology that can be caused by the inflammation, enteritis, by the surgical intervention, resection of the small intestine, by the syndrome of insufficient absorption, with the exacerbation of the gastric ulcer or the adrenal ulcer, dysphagia, swallowing disorders, hemodialysis, mental disorders, absence of consciousness or impairment of consciousness. All of these are indications to go for the parenteral therapy. And the most common reason here, it is malabsorption. There is quite easy test in order to see how exactly iron is absorbed in this certain patient, so-called iron tolerance test. On the practical classes, we will discuss that in the details. Now, just few words. The patient will be given 2 tablets of the iron content, with the total weight, with the total content of elemental iron, 200 milligrams. So, for example, 2 tablets of the Sorbifer Duraless. And after that, I would say periodically, dynamically, the level of the serum iron will be detected in the blood, starting from 1 hour after intake of the iron supplements. If we can see that after 2 tablets, absorption, when the patient took 2 tablets of the iron content, for example, when we can see, so 2 tablets with the elemental iron equal to 200 mg, when we can see that the serum iron is increased by at least 100 mg within 1 hour or maybe after 2 hours, we can be sure that the iron content is successfully absorbed. But when the serum iron is not increased, we will have to go for the parenteral treatment of the iron deficiency anemia, because in other cases, when we continue oral therapy of the iron preparations, and this iron is not absorbed, this treatment is useless. We're just wasting our time. There is no any effect, no any favorable changes of the biochemical analysis, no any changes of the CBC will be detected, because our therapy is useless and parenteral therapy must be used here. Complex iron preparations. So iron complements with the folic acid or with the thiancobalamin, for example, with the B12 and so on, considering the combined character of the anemia. How can we evaluate the effectiveness of the therapy? In other words, how do we know that our therapy is good and we are doing well with this patient? First days of the treatment, subjective improvement. Only some complaints will be slightly decreased. By the first week of the treatment, if our treatment is effective, we will see increase in the reticulocytes in the blood. It is very fast, I would say, very short, the earliest changing sign that we will detect. First month after the treatment onset, hemoglobin and the red blood cell count will be increased. 2 months of the treatment, color index will become normalized, MCV will become normal, red blood cell count will become normalized. And finally, by the 6 months, normalization of the quality of life indicators. The treatment of the iron deficiency, of course, that depends on the patient's stage. For example, if we treat late iron deficiency, the stage number 4, it will take 6 months to reach for the normal quality of life. In other words, 6 months are necessary to eliminate anemic and sideropenic symptoms in order to, I would say, recover in the iron stores in the body when the levels of the ferritin, serum iron, transferrin saturation will become normal. Another problem that we will consider today, but just few words, B12 deficiency. Well, usually quite rare situation in comparison with the iron deficiency, but B12 deficiency anemia is much more dangerous. And usually the, I would say, the patients with the B12 deficiency, they feel very, very uneasy, and it's usually much more severe condition. What is B12 or cobalamin? It is external factor that's usually observed after binding with the intrinsic causal factor with the stomach. In the case when the intrinsic causal factor is absent, only 1% can be observed. So, cobalamin is involved as a cofactor in the synthesis of nucleic acid, in the synthesis and regeneration of myelin, in the metabolism of the fatty acids. And in other case, when the B12 is decreased or may be absent, it will lead to B12 deficiency. Most commonly, the following reasons can lead to that: food deficiency, lack or absence of intrinsic causal factor, so pernicious anemia with the congenital or adult form, after the stomach surgery, dysfunction of the intrinsic factor, impaired absorption of vitamin B12 or biological competition. Changes in the gastric mucosa with the pernicious anemia. As you can see, there is, well, quite clear damage to the, I would say, micro structure of the stomach membrane. Pernicious anemia, characterized with antibodies to parietal cells of the stomach, and in this case, this condition is usually combined with the presence of autoantibodies to the thyroid gland. So hypothyroid condition will also be present. So blue eyes, early gray hair, vitiligo, hypothyroidism, and diabetes are one of the most common concomitant conditions. The clinical manifestations are much more severe, and B12 deficiency always includes the damage of the nervous system, so-called funicular myeliosis. Typical triad of symptoms: general weakness, severe weakness. If the patient with the iron deficiency has only decreased physical tolerance, the patient with the B12 deficiency has increased willingness to lie down and not to move at all. Painful tongue, glossitis, and paresthesia. The certain nervous system damage always present in these cases. Possible hemolytic component of anemia: splenomegaly, yellowish skin tone, megaloblastic type, glossitis, angular cheilitis, associated inflammation of the angulars of mouth. Here are the neurological manifestations. Depending on the degree of the funicular myeliosis, B12 deficiency anemia must be classified as a mild, moderate, and severe. Mild: only absence or weak manifestations of the impairment of touch and temperature sensitivity. Moderate: decrease in vibration and positional sensitivity. And finally, severe: increased reflexes, clones, pathological reflexes, gildal pain, hypertension, dysfunction of the pelvic organs, mental disorders are also possible. So when we classified iron deficiency by the stage, B12 deficiency must be classified depending on the nervous system damage. Laboratory signs of B12 deficiency. First of all, it is macrocytic type, MCV more than 100 femtoliter. Color index is increased, so this is hypochromic type of anemia. MCH and MCHC are all increased. Also, one of the specific types of the findings, rings of Cabot and Howell-Jolly bodies. Remnants of them. So we keep in mind megaloblastic type of the erythropoiesis here. When immature forms of the red blood cells enter peripheral blood with the remnants of the nucleus. And here are they. Cabot, rings, and Howell-Jolly bodies are nothing but the remnants of the nucleus. What else? Thrombocytopenia is one of the common symptoms. Decreased B12 concentration, antibodies to intrinsic causal factor, to the gastric parietal cells in the case of the pernicious anemia, increased methylmalonic acid in the urine, and so on. But usually, the common signs of the B12 deficiency, they are megaloblastic type erythropoiesis, the puncture of the bone marrow is very necessary, MCV more than 100, hypochromic character of the anemia, well, rings of Cabot, Howell-Jolly bodies. That's it. This is enough to confirm the presence of B12 deficiency. Here are they. Macrocytosis, hypochromia, ovalcytosis. Blood and bone marrow patterns in the patient with the B12 deficiency. On the right, we can see the megaloblastic type of the erythropoiesis in the bone marrow. That's it. Normoblasts with the immature nucleus. The treatment. Unlike iron deficiency treatment, B12 deficiency must be treated during the lifetime long period. So it's not just like 6 months and we can finish that. No, the patient with the B12 deficiency will have to receive B12 vitamin during whole of his life. First of all, we must eliminate the cause, but usually that's not possible. So after that, we will give intramuscular with the intramuscular injection of the cyanocobalamin for 7 days. When we can see that the reticulocytes are increased, the same dose will be given for 2 weeks, then only once a week for 2 months. With the severe neurological symptoms, it can be given intravenously. Maintenance therapy, please pay attention, 200 mcg per day, every week, 1 time per year. So per year during the whole life. B12 deficiency anemia must be treated without any end. And well, another problem can also be associated with similar symptoms. It is folate deficiency. So nutritional deficiency usually leads to that. Increased consumption in the case of the pregnancy. Pregnant women are always diagnosed with the folate deficiency because it also can have some unfavorable consequences for the fetus. And so usually the folic acid supplements are given as a common, regimen drugs for the pregnancy. Well, clinical symptoms, usually similar with the B12 deficiency. The only exception is neurological symptoms are usually absent here. So that's it. Spontaneous skin hemorrhages with the megaloblastic anemia. Data insufficiency of the folic acid and alcoholism. The treatment of folate deficiency is given folic ACID every day, 1 up to 5 mg during approximately 1 month. Usually, really calcium folinate intravenously or intramuscularly, or maybe combined drugs. That's it, students. My lecture is finished.